Okay, so it's 7 o'clock. Welcome, everyone. We will go ahead and get started. This is session 4 in the Foundations in Critical Care webinar series. And session 4, we will be talking about obstructive shock. We are happy to welcome Dr. Andrea Komisky as our host today and special panelists from around the world. We have Dr. Awab Dabaliz from Stanford University, Dr. Jackson Ndekezi from Rwanda. Dr. Rebecca Pyland is from Cornell up in New York. Dr. Eunice Gatia is from Nairobi, and Dr. Lisa Rappaport is from Kaiser Permanente here in California. Before we get started, we want to just talk a little bit about some housekeeping. We want this to be a place of respect, so it's a safe place for individuals from various backgrounds to learn together. So please respond kindly and with respect if you disagree with something. We will be using the Q&A function at the bottom of the screen, so please send questions through the Q&A box and feel free to introduce yourself in the chat. If your bandwidth permits, you are encouraged to turn on your video to capture your face or the room if you're in a group. This session is being recorded, and your attendance is your consent to being recorded. This session will be posted on the Learning Resource Center and also live streamed on YouTube. Closed captioning is available. You can find this at the bottom of your screen. This will help with some of the language, and especially for those that are non-native English speakers. The Learning Resource Center is an online learning platform. All the materials will be uploaded to the Learning Resource Center. The Learning Resource Center is always free and open access, and we will share that link shortly. So all the slides and notes from today will be listed there. This webinar has CME credits available. You will receive an email after the webinar, and the link will be shared with you where you can fill out the evaluation form and receive your CME or CPD credits. And that is courtesy of Stanford Department of Anesthesia. So with that, we'll turn over to Dr. Andrea Komisky, and we'll get started on shock, a 4-part series.
Thank you, Dr. Crawford. We appreciate the very warm welcome, and thank you to everybody for joining us today for this 4th part to the shock series. Moving forward, for those of you that have been a part of the last 3 series, we have discussed all different forms of shock. And to just further reiterate and approach shock again, we can describe it into 4 separate categories: cardiogenic, obstructive, distributive, and hypovolemic. We have covered each of these categories in separate sessions, and we will refer back to this one-pager very quickly as an approach to undifferentiated shock. And if you would like to have it available for your own use, hypovolemic.
Andrea, sorry, I'm hearing feedback from the live stream. Are you hearing that as well?
Very quickly,
Yeah.
as
Okay.
an approach.
All right. I think we'll have to stop that. Apologies. Go ahead.
So if you would like to have this as use for your own personal use, you can scan the QR code, which is on the right side of the screen. And the one-pager is available for download as well on the LRC if you have had access to it, or we can put the link in the chat for you all to have access as well. It is important to remember that patients can have multiple forms of shock and not just stick to one. So for example, you can have both distributive and obstructive shock, or distributive and cardiogenic shock at the same time. And it is important to recognize and treat causes immediately. Today, we are going to focus on obstructive shock. So if you think of blood pressure as perfusion as a tank, pump, and pipe system, obstructive shock will refer mainly to a pipes problem due to a physical obstruction.
Great. So just a quick refresher on what is blood pressure and what we really why we really care about it. So when we talk about oxygen delivery to the tissue is really the basis of what we really care about. And unfortunately, we don't have a really good way of assessing individual cellular oxygen delivery. Um, and so we really use blood pressure as a crude or very generalizable substitute for that purpose. Um, so the components when we think about blood pressure, we should think about the components of blood pressure, right? So we have our cardiac output and we have our systemic vascular resistance. Cardiac output, or what we refer to as the pump function of the heart, it is basically the volume of blood that is pumped by the heart over a period of time. And so we use the measures of liters as the volume for the volume, and then over a minute to calculate our cardiac output. And those are determined by our stroke volume and our heart rate. So the more stroke volume we have, or the more heart rate we have, up to a certain degree, we can have a higher cardiac output. And our stroke volume is usually resultant based on our preload, our afterload, and our contractility function. When we talk about our systemic vascular resistance, or what we think about as the piping, as Dr. Kaminsky was talking about, we can think about it as the force or the resistance that's exerted on the circulating blood by the blood vessels. And there are different factors that affect our systemic vascular resistance, or SVR, and that would be length of the tubing. So more length means more resistance. Diameter of the tubing, less diameter, more resistance, or the viscosity of blood itself. And so more viscous means more resistance. And so the diameter is really something that our body can regulate using the sympathetic and parasympathetic system. And so that is what we refer to as the vascular tone. And that's something that we can adjust to change the SVR under normal situations. And then another way to think about SVR is it's the force that the LV, or the left ventricle, must overcome to pump the blood into the aorta. When we talk about the most common types of shock, or epidemiology of shock, unfortunately, we don't really have good data outside of high resource settings looking into what's more common. However, in high resource settings, we can say that there are studies that looked into this, and it definitely varies depending on the type of institution. However, on a generalized sense, septic shock seems to be the most common type of shock, greater than 60%, all comers with shock. When we look at the second most common, or second and third, it would be actually cardiogenic and hypovolemic at around 16%. And then followed by other types of distributive shocks, such as anaphylactic shock at 4%. And then obstructive shock comes last, is 2%. And so it's really important to have it at the back of our heads. Is you can see that it's not something that a lot of people working in the ICU or in the critical care or emergency care setting will encounter unless they work in a specific critical care setting. But it's really important to keep that in mind as you move forward. Again, we don't unfortunately have good data in lower resource settings.
So today we are discussing
Apologies.
obstructive. Oh, you got it, Lisa? Okay.
I'm sorry. Yeah, I was just muted. I apologize. Okay, so today we are discussing obstructive shock, which is one of the different forms of shock. And let's just move on to the next slide, please. Okay, so the objectives for today are to discuss the equation for blood pressure and cardiac output, and hopefully understand that by the end of the session. The idea that we would be able to identify and list the 4 categories of shock. We want to identify clinical signs and symptoms of obstructive shock early. They can be subtle, but the earlier we detect it, the more time we have to intervene on that. It is indeed a medical emergency, and so it does need to be intervened on as quickly as possible. We're going to talk about the most common etiologies of obstructive shock, and we're hopefully going to understand the management and treatment steps for this complicated situation. Thank you.
So, as we've done with the last several sessions, we tried to make these case-based discussions in order to make them as comprehensive and coherent as possible. So today we have our patient, and her name is going to be Mrs. Diaz. She is a 33-year-old female who is now 14 days postpartum from a spontaneous vaginal delivery. She has been discharged home after her delivery on postpartum day 2 and is now returning to the emergency department with sudden onset of shortness of breath associated with syncope. And she had near collapse on arrival at the hospital. And she is also noted to be pale, diaphoretic, and confused.
So to the audience, what are the most common causes of obstructive shock? You're gonna go to the chart messages and then try to give answers for this. We're gonna give 30 seconds and then shall discuss afterwards.
Great. Yes. Thanks, Dr. Jackson. So everyone in the audience, please put your answers in the chat box. What are the most common causes of obstructive shock? So we're looking for at least 2 to 3 answers from you in the chat box.
So, the most common cause of obstructive shock is a pulmonary embolism, especially for our case.
Thank you. Or I can see that our chat is really moving forward, and looking at them, maybe Alana gonna help us to show us some of the results. But as you can see, the most common causes of obstructive shock are massive pulmonary embolism. You may also have cardiac tamponade and tension pneumothorax. As my colleague said, we do not know the statistics in LMICs, but in high-income countries, you also that there are some of the statistics that are showing these are the most common. But with these charts and the literature says that we have other causes like of obstructive shock, such as restrictive cardiomyopathy, severe aortic stenosis or constrictive pericarditis, but these are far less common than the other listed above. Yeah, into the chart you can see that some of the participants listed congenital malformations, but these are all less common. So we're gonna go through what is really the obstructive shock. By definition, the obstructive shock is a state where you have, of course, as we know, all of us, shock is a status where there is reduced metabolic demand compared to the supply. With that, with this obstructive shock, it's just anatomical obstruction of the great vessels that are either bringing blood towards the heart or excessive afterload. There is obstruction to the forward movement or forward move of blood. And this will result, of course, of decreased cardiac output. In addition to the signs and symptoms of shock, such as low blood pressure, elevated lactate, or decreased urine output, there are several defining characteristics found in patients presenting with obstructive shock. Patients with obstructive shock generally present with hypotension. Of course, when they are still into compensation, they may have tachycardia, and generally, which is associated with compensation, and possible imaging findings that are confirming that there is an obstruction, like such as pneumothorax, pericardial effusion, or right ventricle strain, and massive PEs, pulmonary embolism, will be identified on CT scan imaging, or in case you have VQ scans in ideal settings. So
Discussing-
about
So discussing some of the, oh, sorry, are you going back?
So as you can see, with massive pulmonary embolism, it's sort of just failure of moving blood effectively across pulmonary vasculature. And when there is cardiac tamponade, it's just an abrupt or onset of fluid collection into the pericardium that is compressing the heart. And when we have tension in pneumothorax, just air trapping into the pleural space that is kind of compressing onto the great vessels or even the heart itself. And in case of severe aortic stenosis, just fixed obstruction of the forward flow of blood or the left ventricular outflow. And there we have mediastinal masses, like some of them listed them into the chart. These are rare, but they can be obstructing, like the superior vena cava syndrome. These are all conditions that can be obstructing blood to go to the heart.
Anything else, Dr. Jackson?
So, in fact, to summarize this, it's just anything that obstructs blood that prevents or impair the venous return, a fully functional venous return, or anything that's obstructing blood for a forward movement or outflow from the left ventricle. I think that's it. If there are other comments or any other
I think it's
question, will be just drawn into the chat.
one thing that has happened in the chat is talking about embolism and the different types of embolism. So you can have a blood clot that can embolize, but also you can have amniotic fluid, you can have air, you can have fat. So there are different types of embolic phenomenon that can lead to obstruction. So just to remember that point.
Thank you.
Now, if you have a patient who presents signs symptoms of obstructive shock, which we'll go over in a little bit more, you have to these are very sick. This form of shock is so, more high fatality even in high resource countries.
Dr. Pylon, for some reason, we can't hear you. You're breaking up a little bit. I'm not sure if it's the internet connection or can we try again from the top?
Let me see. Yeah, I'm stopping my video to see if that helps. Can you hear me better?
Yeah, it seems to be slightly improved.
Okay. So all of these morbidity and mortalities related to our obstructive shock phenomena, we have, they're all very rapidly fatal, especially setting. So things like massive pulmonary embolism, which is greater than 50% occlusion of the great pulmonary vessels, will result even as much as 65% mortality, even in high income or high risk settings. In hospital mortality is also very high. Cardiac tamponade, if it occurs acutely, is very fatal within minutes. If it's for accumulation of blood or fluid around the heart, it can have a little longer time, but it also requires treatment itself. Tension pneumothorax, as you can imagine, that midline shift in an occlusion of blood back to the heart is 100% fatal, but often has a very approachable solution, depression or a chest tube. And in the long term is fatal due to a sequelae, meaning that your right heart will begin to fail because of your left heart failure and getting blood out of the left ventricle. Some more morbidity considerations, if we are able to appropriately treat them, is that PE often have chronic hypertension, which is the WHO classification for types of pulmonary hypertension. And this can cause a obstructive shock in itself with high afterloads for the ventricle. Tension pneumothorax and tamponade often can have neurologic problems due to that outflow or lack of getting blood to the left heart, causing neurologic impairment or perfusion for prolonged periods. And then again, aortic stenosis is a long-term sequelae caused problems by this recurrent heart failure and poor functional status.
Okay, so thank you, Dr. Pyland, for giving us the morbidity and mortality. As you can see, all of these are very highly morbid conditions and carry a high degree of mortality with them. So this discussion is even more important to further understand the signs and symptoms to look out for a fast and appropriate diagnosis. So coming back to our patient, Mrs. Diaz, upon further questioning with her family, who's at bedside, the delivery was complicated by some mild postpartum bleeding, but since then she has not had much bleeding since coming home. When she arrives, her blood pressure is noted to be 80/50 with a heart rate of 125. She is tachypnic with a respiratory rate of 30 with an SpO2 of 88% on room air. And on physical exam, you note that she does have jugular venous distension or JVD. She is tachycardic on auscultation, however, has very clear lung sounds bilaterally, and she has a very loud P2 heart sound. When you feel her extremities, appropriately so, you note that they are cool and that her left leg is more swollen than the right based on visualization. So my discussion question for you all is, what's on the differential list for Mrs. Diaz? And I'll give you 30 seconds to just type in the first top diagnosis that you can think of, just to further spur some thought process and discussion amongst you all.
Okay, everyone, put your answers in the chat box. What's your differential diagnosis? I see some good answers coming in already. Great. Most people think this is a DVT leading to a pulmonary embolus, Dr. Komisky.
Love it.
Someone says hemorrhage. We can talk more about that. Hemorrhagic shock, septicemia. Those are some other differentials.
And
Sepsis.
these are all great things to keep on the differential because, as we stated earlier, patients can have more than one thing going on. So making sure that you are keeping everything in the toolbox and rolling things out appropriately is the right step.
Great. Should we move on? Lots of the same answers coming in.
Yes. Thank you.
So as mentioned, even from the answers, we have seen that the patient has can be a combination of different factors. So maybe from we will see for this patient, why would we think that this patient has a hemorrhagic shock? Maybe someone can type in the answer we see. What is the cause of hemorrhagic shock in a postpartum patient? Someone says postpartum cardiomyopathy, PPH, yes, PPH.
Someone said
So,
uterine atony. That's good. That's a good answer.
yes, uterine atony, losing the placenta, true. Yeah. So mainly in this patient, we said there was some mild bleeding post delivery. So that could also be a differential diagnosis for this patient, postpartum hemorrhage or uterine atony. So most of the key features, what would you expect to see in a patient with hemorrhagic shock? Yes, I see hypotension, tachycardia, pallor. Thank you. Vaginal bleeding. Thank you. Cold extremities and hypotension. Thank you. Everyone is very alert. Good. Postpartum bleeding related to retained products of conception. Good. So I think you have a good grasp of the hemorrhagic shock in this patient. So the other differential, someone actually wrote there, sepsis could actually be one of the other differential diagnoses. So what are the key features that we will see in sepsis, like in this patient? What will we expect to see in sepsis? Key features in septic shock, pallor, fever, hypotension, yes, low blood pressure, warm extremities, that is true. Hypothermia, fever, pallor, low BP. Okay. Yes. So the answers pretty much true. It looks like you did a very good job the other classes, the sepsis. So what is the from here? What are the common causes of septic shock in postpartum in the postpartum period? What would trigger a patient and tip over a patient to get septic shock? Infection, endometritis, retained POCs. Okay, thank you. Prolonged sepsis, retained placenta. Good, yeah. So we seem to have most of the answers in there. Chorionitis, that's true. Hygiene, septicemia. Good.
Dr. Eunice,
Thank you.
you cannot trick these participants. They are so smart. They're getting all your answers.
Yes, all the answers are just coming in. Yeah, so this is
Great.
so good. Yes. So also, someone had also mentioned something about cardiogenic shock. In this patient, are we likely we are likely to also have maybe a differential diagnosis of cardiogenic shock? What are the features of the cardiogenic shock that you will be looking out for in this patient? Hypotension, thank you. Low blood pressure, true. Tachycardia or bradycardia? What would you expect to find in this patient? I'm seeing muffled heart sounds, hypotension. Yeah. Okay. So bradycardia and low SpO2. What are the causes that will give you cardiogenic shock in this in postpartum period? Dilated cardiomyopathy, that is very common. Autotransfusion, thank you. Cardiac tamponade, that will end up being in the obstructive. Postpartum cardiomyopathy, that is mainly. Also, we may have some patients with undiagnosed heart issues, maybe their valves, valvular issues. So maybe when they get an overload, they may not be able to handle the volume, especially after the autotransfusion, which can also trigger the cardiogenic shock. Thank you. And MI also, thank you.
Yeah, and
So
MI is actually, Dr. Eunice, MI is a very important one to point out because we do have a rise in our non-communicable diseases and risk factors for cardiovascular and cerebrovascular diseases. So even in a young pregnant woman, MI is certainly possible.
yes. And also, especially also combined with patients who may also have issues like aortic stenosis. That is also a very common feature to see. You may see an MI in those patients. Lastly, obstructive shock. Most of you had mentioned, what are we likely to see in the obstructive? What are the key features in this patient that will guide us to see it's obstructive? Raised JVD, okay. High output cyanosis. Someone says cyanosis. What else? What are the key features? JVD, cold extremities, swollen leg. Yes, thank you. Swollen feet. Thank you. So we seem to have a grasp, hypotension, dyspnea. Thank you. So some of the common causes of obstructive shock, we had already gone through them before, and most of you had given good answers. The DVT, we can have tension pneumothorax. Okay. Yeah, so I think that's a good grasp of it. Can move to the next slide. Yes. So for this patient in particular, since we are also thinking about obstructive shock in our physical exam, what will we be looking out for in this patient given the history that came in? Just type in the chat box what we expect to find. What are the physical chest pain? Thank you. Raised JVD, JVP, thank you. Edema, there may be tachycardia. What else? Cyanosis, thank you. Nice answers. Swelling of both limbs, tachycardia, more or less hypotension, more or less the same answers, but good. So in this patient, we had said that we are likely to have, most of you said pulmonary pulmonary embolism. So hypotension, tachycardia is common, raised JVP, diminished breath sounds. It could be either unilateral, depending on where the clot may have settled. Also, we may find some features of tachypnea, features of difficulty in breathing are things that you look out for. We have a narrow pulse pressure, cold, clammy extremities, muffled heart sounds, if it is a tamponade also. Okay, thank you.
Okay, so thank you, panel so far. So right now, let's make an assessment. So we talked about the signs and symptoms, right? We talked about the presentation. We need to say that this patient has what we think is shock, right? So we have signs and symptoms consistent with shock, and so we need to think about that actively and say that and voice it. And then we need to and we have evidence of that, right? So we have signs and symptoms like hypotension, tachycardia. We have the poor markers of poor perfusion with a cold extremity. So all these things make us sure that this patient is presenting in shock. Now, as all of you indicated, this is seeming to be an obstructive type of shock in the setting of this swollen leg and the postpartum status, putting the patient at risk of a PE. And so obstructive shock in the setting of PE is the likely presentation of this patient based on the history and physical exam findings. And it's really important to say that because when we think of shock in the setting of PE, it really means that we're in a pretty advanced stage when it comes to the PE or acute PE presentation. We'll talk more a little bit later about the stratification and classification of PEs, but it's just interesting to look at this graph here on the left-hand side and see how the mortality is pretty much exponential once you reach the shock state with PE. So that's something to keep in mind with these acute PE presentations, and cardiac arrest can happen pretty soon after a shock presentation with PE. So it's really important to pick it up early and address it appropriately. We also have, I don't want to belabor the different types of shock again, because clearly you guys have a great understanding of them. So I think we can move forward with that.
Yeah, I'll just say one thing, Dr. Wab, is that is one of our learning objectives, and I think that our participants recognize this readily. But all forms of shock can be rapidly fatal, and so they're all considered medical emergencies. And I think your slide really demonstrates this very well with that curve and how things can progress really quickly towards fatality. So thank you so much for demonstrating that for us.
Thank you.
Okay, I'm trying again. Can you hear me?
Beautiful. Yes.
Okay, sorry about that, everyone. So this slide is kind of, the goal is to give us a good visual representation of what obstructive shock looks like at the vessel levels and at the pump level. So it's due to a blockage in preventing blood either getting to the right heart or leaving the right heart and getting to the left heart. And if we think of it as a sequence, you can see that is how we have less cardiac output, is because we can't fill the left because we can't get either into the right or over to the left heart. And so it occurs because of these anatomical blockages. In this first picture, you can see in the upper corner is the fluid that surrounds the heart that is putting pressure on a weaker right ventricle, causing collapse. And so the fluid on the outside of the heart has a higher pressure than the blood in the heart, and it causes collapse of that ventricle. And that may be due to somewhere in the vena cava, as you can see on the picture, on the lower picture. It may be due to the pericardial sac, which is around. And then an afterload problem of the right heart, or a problem of getting from the right ventricle to the left ventricle, is in the pulmonary vascular system. So these, if you break it down and think of it sequentially, like, is it a problem getting to the right heart? Is it a problem getting from the right heart to the left heart? Or is it a problem getting out of the left heart? You can start thinking about where your pathology may occur. And this next picture is one of my favorite learning tools, at least when I talk to my residents, is how the right heart responds to these changes. And if we start at the top, it says pulmonary hypertension, but essentially that's an afterload problem. So in a pulmonary embolism, you have high afterload due to occlusion of your pulmonary vessels. And that, let's follow the spiral down. You go from the pulmonary high blood pressure, and it causes the right heart to struggle, especially in the acute setting. The right heart is much weaker than the left heart, and the way its muscles are oriented, it does not respond well to dilation. So it has an increase in wall stress, which causes if it's a prolonged process, it causes the RV to hypertrophy, to build up extra muscle. But in the acute process, it doesn't have time to do that. So it just dilates. And that causes the midline of the septum to shift towards the left ventricle, because it is much higher pressures, because it's trying to get over the pressure of the afterload, as well as you still have preload coming in. So you get dilation. The dilation of the right ventricle causes the tricuspid valve to dilate as well. So you get severe regurg. And so now you have another reason why you can't get from the right heart to the left heart. This causes a right ventricular ejection decrease, which would cause less blood in the left ventricle, which causes less blood to leave for the body. And you can see how this spiral can be rapidly progressive and can lead to failure of output into the body, and thus causing shock, and ultimately poor coronary perfusion, which feeds back again. Our right heart doesn't get the oxygen it needs, and then can cause cardiac collapse.
Okay, so let's talk about how to investigate all of these differential diagnoses that we've been talking about. And I just want to start by saying that I think that the most important diagnostic tool that you have is your clinical acumen and your suspicions, right? So all of these tests that we're ordering, they're either helping us to confirm or refute the ideas that we already have going in our mind. And our minds are so powerful, we may not even realize that we're doing these differential diagnoses, right? We've had them trained into our practice over many, many years of really just having the same, doing the same algorithm and pathways over time. So I love picking tests that help me confirm or refute what I already think is my suspicions, also known as pretest probability. So probably want to order some laboratory studies if available, such as a complete blood count. We'd order a metabolic profile, chemistries with electrolytes. Troponin would help us to find out if there is any heart cell muscle death. We could see troponin leak in a PE. Lactate is always useful in looking for underperfused tissues. And a BNP, a beta natriuretic peptide, is helpful to determine the degree of shock that's happening. So very often, for example, in a PE, we'll see a mildly elevated troponin and some middle elevated BNP. But if the BNP ends up being very, very high, then and the troponin is negative, we may want to consider moving more towards a cardiac source of shock. But I always keep the differential open. Imaging, ECG, right? Someone had mentioned in the chat about S1Q3T3, which is a pathognomonic EKG pattern for acute RV failure. It can also be seen in acute RV myocardial infarction, by the way. Echocardiogram, which I have to say that is my go-to choice for diagnostics for obstructive shock. And we'll talk about that a little bit later in our slides, but I find it rapid, and the same person that is asking these questions about differential diagnosis and possible etiologies is the person doing the test, as well as is the person interpreting the test. And we see the same thing for lung ultrasound, two points down there. Chest x-ray, always important to look, although it's always embarrassing when I order a chest x-ray on someone with a tension pneumothorax because I should have heard that there was no breath sounds on one side or the other. And then perhaps for more resourced areas, a CT pulmonary angiogram, where the contrast of the CT is timed with the cardiac cycle so that we get dye into the pulmonary vasculature and we can look for filling defects in those pulmonary arteries. And a VQ scan, I think, needs to be mentioned, although I use this very rarely in my practice, but it does take a long time to get your answer back from the VQ scan, and it is also sort of very murky. It doesn't give you a slam dunk answer. It doesn't say definitively yes or no. It says high probability or low probability. So in the setting of someone having a really profound shock in extremis, a VQ scan is usually less useful. Next slide, please. So pulmonary embolism, and of course, this is my favorite diagnostic tool is ultrasound. And you should all know that I'm very biased. I'm very pro ultrasound. So forgive me for just letting my allegiance shine through here. But what we're seeing on the top screen, and unfortunately, we're not seeing it in movement, but you can get the shape of what's happening. On the left side of the screen, on the top image, we see the right heart. And on the right side of the screen, we see the left heart. The right heart looks significantly larger than the left heart. And that's the first tip-off that we're dealing with an acute or potentially chronic, but acute on chronic right-sided issue, because the right heart should really only be about maximum 2/3 the size of the left ventricle. So that's the first tip-off that we're seeing something highly abnormal on the right side here, and that the right side of the heart is stressed. Oh, thank you so much for those motion clips. And on the bottom here, we see two more views. the top view, and then on the bottom screen on the left, we are seeing something called a apical 4-chamber. And then on that right most bottom corner view, we're seeing an apical 2-chamber. And these are all just ways of looking at the right versus the left heart. And again, most predominantly, what jumps out at your visual interpretation here is that the right heart is struggling. It's larger than the left heart. And we're seeing on that top part, I think what we're seeing is the indentation of the right atrium, perhaps with some clot pushing in on it. That's one type of shock. And then on the bottom 2 images, we're seeing like a really, really sluggish looking RV that's struggling to pump forward. And I would suggest that's probably from a PE. Okay, next slide. Thank you.
Dr. Rappaport, one of the questions in the chat that I think might be good for us to answer now is, can you find cardiomegaly on X-ray when you have a pulmonary embolus?
Oh, these are great questions.
Yeah.
And here's the thing about, actually one theme that I've seen in a lot of our discussion is time course, right? Aortic stenosis causing obstructive shock versus congenital malformations. And now we're talking about cardiomegaly. So in an X-ray, it's unlikely, and please anyone step in if they disagree, unlikely to see cardiomegaly unless it's chronic. An acute cardiomegaly, you can see a little bit, but not as it's not as easy to see as on an ultrasound. That doesn't mean, though, that patients with chronic cardiomegaly don't get pulmonary embolus or pericardial tamponade. So it's not necessarily helpful to rule in or helpful to rule out. I think the best view of a heart acutely comes from an echocardiogram. And forgive me, again, that's my bias. If anyone disagrees,
Yeah, no, I agree with you, Lisa. And I think thinking about a chest X-ray, the portion of the heart that you're going to see most prominently is going to be the left ventricle. And so the right side of the heart is really a bit away from you, and that's what's more likely to dilate in an acute pulmonary embolus. So you may or may not have cardiomegaly on a chest X-ray, and I would say that that's not sensitive enough to really help you rule it in or rule it out. So I like how you mentioned that your clinical suspicion and the clinical context of what's happening with the patient is really the most important part. And I agree with you, looking at cardiac function with an ultrasound is probably a better way to assess for pulmonary embolus.
Thank you. I do want to mention, though, that sometimes after I see a pericardial effusion, a large one, on an ultrasound, I'll go back to the X-ray, and then I can kind of see, oh yeah, that heart looks really dense. Like there's a lot of radio opaque material around the heart that makes it look brighter than normal. So but that's usually something that I only see when looking back at the chest X-ray after my ultrasound.
Yeah, and so I think pericardial effusion is quite different than a pulmonary embolus as a cause of obstructive shock. So that those two chest X-rays might look quite different.
So with that, let's see the other causes of obstructive shock. And among them, as we all had with the previous presenter, we just saw there is cardiac tamponade. And then we just saw all these Beck's triad and during the charts, and everyone just talked about it. We have kind of this classic clinical presentation of hypertension, jugular venous distension due to obstruction of blood or obstruction of blood towards the heart. And then you're going to have muffled heart sounds, which is mainly due to this kind of impaired sound due to collected fluids that is kind of mimicking sounds. You can't hear sounds when you auscultate. Now here comes Parsus paradoxus, which is into the settings where we do not use arterioline. You may not know it, but this is kind of most seen when we're using invasive hemodynamic monitoring, such as arterioline. and this is explained by a drop of more than 10 millimeter of mercury during inspiration. And this, do or that during inspiration, you're gonna add more pressure to the intrathoracic organs. With that, you're gonna have like more compression to the heart and great vessels. And this is gonna reduce to the blood pressure, mostly the systolic blood pressure by 10 millimeter of mercury. And then when you just exhale air out, this is gonna be kind of resolved. And this
Dr.
is a
Jackson.
very, yeah.
I just want to point out one small detail about inhalation and exhalation, and whether or not the intrathoracic pressure is positive or negative. It depends on whether the patient is breathing spontaneously, which would have negative intrathoracic pressure, or whether they're on a ventilator that uses positive pressure ventilation. So that electrical alternance may differ depending on the patient who's breathing spontaneously versus positive pressure ventilation.
That's a very good input because sometimes you may get this having a patient in ICU or on operating table under anesthesia. Thank you. The other thing that you can have is electrical alternance, which is alternating QRS complex amplitude that's kind of swinging within the pericardial sac, and this gonna be showing like a seesaw motion with amplitude of the QRS complex on an EKG. And this again shows that in our low and middle income countries, we need to pay much attention to our EKG when we are doing any intervention during anesthesia or when we are monitoring those patients at emergency. The other thing that Dr. Riza mentioned a lot is a point of care ultrasound, which is mostly available in our settings, very easily accessible, and then it is showing high sensitivity when you're using it. And with that, it also giving you faster results and less costs with less side effects or kind of consequences when you're using it. With that, with the point of care ultrasound, you may have pericardial effusion, which is fluid built up around the heart into the pericardial sac. And then you're gonna see that mostly the right ventricle, which is mostly susceptible to pressure, external pressure from the effusion, will be compressed. And then sometimes if the patients have been mostly fluid depleted, you're gonna have the fluid depleted or not, it will depend to the status the patient is in. You're gonna have the plump IVC. Next slide. So the other thing that you're gonna see with these patients is the tension pneumothorax, which is leading to again to obstructive shock. This is a very common occurrence in LMICs again, and this has been sometimes missed by co-workers. Guess what? When you do not go straight to the X-ray or something, but when you know the clinical presentation of this, you can't miss it. It's a clinical diagnosis, and sometimes you may need some other like investigation to confirm. But the presentation is typical, and then you go ahead and manage. Patients will come to you complaining of chest pain, shortness of breath. When you go on an auscultate, you're going to have decreased or absent breath sounds unilaterally, as all this may be affecting one side. I've never seen so far into my career having bilateral pneumothoraces, but you may also have tracheal deviation towards the normal side and hypotension, which is associated with this shock, tachycardia when the patient is still compensating, and When the patient is not really perfusing, where of course oxygen will gonna not get to where it is going to be found, and then the patient may have cyanosis. However, in some conditions or circumstances, you may just perform X-ray in case you need to do decompression or putting test tubes. And the mainstays of tension pneumothorax are the following. The following, in case you use an X-ray. When it's a large unilateral pneumothorax, you're gonna have evidence of lack of lung markings on chest X-ray, and tracheal deviation, which is seen above and designation by the red arrow, as you can see on this right side of the right side of this image. You can see that the trachea is deviated to the right side, and the left side of the chest looks really having too much air or hyperinflated due to this. And sometimes, if you're not familiar with pneumothorax, you may not find a collapsed lung, but those who are familiar, you can see that this lung, the left lung, is completely collapsed. Though the X-ray is not really sensitive for massive tension pneumothorax, but you can get the micro pneumothoraces when you do X-rays, mostly to the critical care or critically ill patients in the ICU. But in acute phases, the tension pneumothorax is quite a clinical diagnosis. Next slide. So the other thing that really is really best of care in terms of this advancement in clinical practice is ultrasound. The ultrasound, as we said, is readily available, very accessible, not really giving too much cost. You can use it on bedside, and it's really depending on who is using it, you can just detect pneumothoraces upon just doing chest ultrasound or just scan. On the right side, you can see that we have we have the lip, and then you can see the shadow of the lip. But on the other side, you can see that we have it demonstrates appropriate or normal lung sliding. Um, and when looking at the green arrow, you can see that you have the shimmering scene, which is a partial or visceral pressure moving against each other, representing appropriate and lung expansion. But when you go to the left side, you can see that the red arrow is showcasing the lack of lung sliding. This lack of lung sliding is pathognomonic of pneumothorax. And in the appropriate clinical scenario, the diagnosis of pneumothorax or tension pneumothorax can be made with ultrasound very acutely and genuinely.
Um, so, thank you, Dr. Jackson. We're going to go through like a point of focus ultrasound, especially in like just the basic in terms of how you're able to do spot diagnosis and easy ways in which you can just manipulate a cardiac probe even without so much experience. There are few things that you can be able to pick up from the ultrasound. I know looks like a lot, but I'll just try and there's a QR code there. Maybe you can all do a small just scan it so that we can be able to go through it. But the main thing, like in this first slide, we have some basic cardiac views that are very important and very basic for us to be able to assess like this patient. So we can be able to easily tell and differentiate what is causing, is it either obstructive or is it cardiogenic? And it can easily guide us in how to manage this patient. So, like in this first slide, I don't know if we can expand it a bit. Uh, we have five, like majorly, like five major views maybe we can talk about, and it will just be an overview. We have like one called the parasternal. We have the long axis and the short axis view. So for the long axis view, you can see the photo of the patient lies on the lateral side. We put the probe on the second intercostal space. And then the main thing that you're trying to assess in this parasternal long axis view is mainly you want to see how the leaflets, you'll be able to see, I wish we could be able to expand, you'll be able to tell like how the right ventricle outflow track is looking like. You can be able to tell if there is blood flow in the right side, and also you can also be able to assess your pulmonary flow. So in this,
Dr. Eunice, I just want to point out that to go through this resource in detail and expand every view is probably outside of the scope of today's discussion. So I
okay,
think what we really
let me,
want
I'll
the
just
learner
highlight.
to realize is that this is a very powerful resource. It's free, it's
Okay,
online. You can scan the QR code. And this has actually three different slides. So this
slides,
this
yeah.
tells you exactly how to do a transthoracic echocardiogram with the multiple different views. It tells you how to assess the inferior vena cava for whether or not it's full. It also helps you with lung ultrasound and scanning for your patient for a DVT. So in the discussion of having cardiogenic shock, septic shock, obstructive shock, this resource is very, very useful. And so we actually just want to provide it to all of our participants. And again, we really encourage you to scan that QR code and download this resource for yourself and spend the time to go through each one of these images. Sorry to interrupt. I wanted to make sure that we don't go through the
Yeah.
whole thing, but that people understand how valuable this resource really is.
Yes, I appreciate, because I thought the scope is actually too wide for me to actually cover in this slide. But just of importance is that what we are trying to highlight from the different views, like from the short axis, parasternal short axis, you can be able to actually tell how the ventricles are contracting. And you, from even that, you can be able to tell the volume status of the patient. So such things are what you will be assessing, and they can easily guide you towards making a prompt diagnosis. Even in the next slide, you're able to see like a four-chamber view. Even from the four-chamber view, you can be able to see how is the contractility of the heart, and we're able to measure like how is the systolic function maybe of the right ventricle. If it is not adequate, can it tip us more to choose if the patient has a pulmonary embolism, or is there a regurgitation in a patient with a valve issue? So this whole booklet is actually very important for you to get a differential diagnosis. Also, the third slide shows the lungs. You should also be able, like the way Jackson had pointed out about the lung sliding, you should always make sure that you're able to visualize the lung sliding. And if there is a break in the lung sliding, what does it indicate? Is it a consolidation? Is it a pneumothorax? If you do not see a continuous lung slide, that is something for you to worry about, and you should be able to probe you to actually do more investigations. If you see an increase in the B lines, Is it an increase in the consolidation? So just use this tool to be able to give you a further differential diagnosis for your patient. Thank you.
Thank you, everyone, for a very comprehensive review on the diagnostics of each of the obstructive shock physiology and pathology that we're reviewing today. So for us, we're going to now return back to our patient, Miss Diaz. We have some results that we've sent off. And so from what we have so far, we note that her ECG has sinus tachycardia. You also note that there's no significant cardiopulmonary disease on her chest X-ray, such as a pneumothorax or any sort of consolidation or effusion that could be causing her shortness of breath. You do her bedside echo, and you note that she does have a moderately dilated right ventricle. She has adequate left ventricular function, no motion, wall motion abnormalities concerning for infarction of the myocardium, and she also is noted to have a full inferior vena cava that's non-collapsible with respirations. You then decide to look at her lungs with your lung ultrasound and note that there's no B lines concerning for parenchymal fluid such as pulmonary edema, and she doesn't have any consolidations. And that you also note that there is bilateral lung sliding in all the different fields that you've checked for. And you proceed with getting a CTPE and note that there is a large embolus within the main pulmonary artery with right segmental and subsegmental artery PE as well. Some of your labs came back significant for a lactate of 2.5, showing signs of hypoperfusion. And you also note that she has an elevated BNP with greater than 1600. And then you also note that she has a troponin leak to 1.2, showing that there is some destruction of the myocardium as well as some stretch of the myocardium as well, causing that BNP elevation.
So we'll use that information in order to classify our patient's acute PE. So there's different ways where we can classify PEs, but if we utilize hemodynamics, RV dysfunction, presence or absence of RV dysfunction, and then presence or absence of myocardial strain or necrosis, those are three different parameters that we can use in order to classify our patient's PE. And so the risk classification is low, intermediate, and high. So three different categories, and then intermediate is subdivided into low and high intermediate. Basically, the most important thing would be the presence or absence of hypotension. If there is evidence of shock in the presence of hypotension, then you will include this patient immediately under the high risk category. If there is no hypotension, if the patient is normotensive, then we look further into the presence of absence of RV dysfunction, which we can use echo or sometimes CT scan in order to identify, or the presence or absence of myocardial necrosis using our troponin and our BNP level, the brain natriuretic peptide. So if one of these two is positive, but not the other in a normotensive patient, that would be an intermediate low risk patient. If both of them are positive in a normotensive patient, this would be an intermediate high risk patient. And then if, as we said, if none of the above are positive, then this would be a low risk acute PE patient. Another thing that is mentioned would be if the patient has a simplified PESI score greater than 1, which I'll touch into a little bit more into the next slide. But just something to keep in mind, this doesn't really this is not specifically related to the size of the PE, although it can be correlated to it depending on the patient. In the next slide, we can talk a little bit about the PESI score, or the Pulmonary Embolus Severity Index. It is basically a tool that we have that predicts, it's a prediction tool that we can use to diagnose PEs, so to assess the mortality with PEs. And it helps us triage patients. It helps us figure out disposition of patients and the different treatment pathways. As you can see on on the screen, you can see the different parameters that are included in the scoring of someone with an acute PE in order to get a PESI score. And then on the right-hand side, you can see the mortality associated with the different scores. So let's do an exercise together and try to calculate our patient's PESI score. Now, a few reminders. A female patient, no cancer history, no heart failure history, no chronic lung disease history. We do have tachycardia greater than 110. We have a systolic pressure less than 100. We have a respiratory rate of 30 or greater. And we have an O2 sat less than 90. And this is, as Dr. Crawford is pointing out in the chat, this is from mdcalc.com.
So I want to also just point out, because there are a few questions within the chat about Wells scores and modified Wells scores in your clinical suspicion of DVT and PE. And this MD Calc link that I put into the chat has all of these different calculators that you can use, not only for this discussion of PE and DVT, but also any type of calculation really within medicine. So it's called MD Calc. It's a really great resource and tool. So feel free to use that link to do your PESI score now, and use it at the bedside anytime you need to do a calculation for your patients.
And a Wells score, my understanding is it helps predict or helps give you an estimate of what's the likelihood of the patient having a PE. A PESI score helps with the severity of patients with confirmed PE. So that's kind of a distinction here. So let's take 30 seconds here and try to calculate our patient's PESI score. Let's assume that the patient has altered mental status for this exercise as well. And let's try to come up with a PESI score. Let's see what you guys get in the chat. So the MDCalc link is in the chat for anyone who needs to utilize it or would like to. And it would be a good exercise to do so you can reference to it in the future. Okay, I see a couple of 150s, 170, 150, 180. $150, okay. So most people are saying 150. So how did we get at that? We said a systolic, a heart rate greater than 110, so that's 20 points. Systolic less than 100, that's 30 points, so that's 50 right there. And then we have tachypnea at 30 or greater, that's 20 points, so we got 70 so far. And then we said altered mental status, so that's 130. And then O2 saturation less than 90, so that's 150. So the answer is 150. And as you can see on the right-hand side, a PESI score greater than 125 is highest risk category of mortality, and that's associated with up to 10 to 24.5% mortality at 30 days. And just quickly, the difference between the PESI score and the simplified PESI score would be that simplified PESI score, if you search it on MDCalc, you'll find it. It basically utilizes very similar parameters, but it's a few less, and it's one score per. So our patient has a simplified PESI score of 3, which is greater than 1. So that's just another consideration. If the patient wasn't hypotensive, it would still be intermediate high risk based on the RV dysfunction, based on the troponin and the BMP and the simplified PESI score.
Oh, why is our patient in particular at high risk? We know that during pregnancy and in the postpartum period that the risk for blood clots is significantly elevated. And this is due to Virchow's triad, which is the 3 factors that you see in this chart here, which show hypercoagulability, venous stasis, and then endothelial injury or dysfunction. So in hypercoagulability for pregnant patients, our clotting factors, as we know, are upregulated. Some are upregulated, some are downregulated, but it makes it so that we're more likely to form clots and less likely to break down clots. And in venous stasis, you have a couple factors here. As the uterus grows, it compresses our major blood vessels, it compresses the IVC, especially in the femoral vessels as well. And also these patients, they are more likely to have less mobility, and they also get venous pooling as they get swelling in their lower extremities. And then, as with any traumatic injury, both vaginal and C-section deliveries cause some degree of trauma to these blood vessels. And so that puts these patients, that especially in the first 6 weeks postpartum, at up to a 15 to 20 times higher risk for a blood clot. And then that puts them at a higher risk for a pulmonary embolus, as we've seen in Miss Diaz here. So going back to the basics, our initial management for these patients should go back to our ABCs, right? So we want to make sure we start with the evaluation of the patient. We've done a good physical exam. We make sure that they're adequately oxygenating and ventilating. We make sure that we've taken a blood pressure and that we've supported that blood pressure the best we can. So that may include supplemental oxygen and that may include vasopressors. And that to an extent, it may include fluids. So what's precarious about this, if we go back to that circle, that spiral that we talked about earlier, is that these patients get volume overloaded on the right side, even though their volume deplete on the left side of their heart. And so when you're trying to support these patients' hemodynamics, it's good to use the vasopressor that may also have some inotropic effect or some cardiac support like norepinephrine. But it also is good to be mindful about the amount of fluids that you use. So the next step is going to be in the immediate period is going to be anticoagulation. And the mainstay of treatment is usually low molecular weight heparin if available. And if not, unfractionated heparin is also an option. Antiplatelet medications such as aspirin are not a substitute for full anticoagulation, but may help prevent like propagation of the clot or worsening of the clot. But getting appropriately risk stratifying these patients for whether or not they are at high risk of bleeding, and then appropriately anticoagulating to help prevent the breakdown of further clot, or sorry, the propagation of further clots. I saw someone mention thrombolysis, and yeah, thrombolysis is part of your downstream treatment. And so I'm going to pass that off because I think we keep talking about that.
Great. So we are running a little bit short on time, so we're going to try to have a discussion about the treatment and management of these things, but may not be able to hit on in depth as much as everyone would like. And so just to refer back to Mrs. Diaz, you place her on supplemental oxygen, 15 liters non-rebreather. You note that her O2 saturation improves. You start her on vasopressors. She started on a norepinephrine infusion in order to maintain her MAPS greater than 65. And then you start her on a heparin infusion and admit her to the ICU for further monitoring, given her high risk of decompensation. You do also reach out to interventional radiology if available at your facility in order to discuss potential thrombolysis. And so our next presenters will go further into the management. And like I said previously, we'll keep it probably not as in depth as you would like, given our time constraints.
So after just with all this kind of supportive care, you need definitive management. That's where you start thinking about thrombectomy or thrombolysis. With that thrombolysis, these are it just uses clot dissolving drugs like TPA. I think some of it's tissue plasminogen activator. That may be readily available to some of the hospitals, but I don't know if all the centers we have in our regions in the low and middle income country have this drug. But at our hospital, we use Artepras, which also is being used to just make sure we thrombolize. The next intervention is thrombectomy, which is mainly done in centers where they have interventional radiologists, which is catheter directed or surgically removed in severe cases of DVT or just pulmonary embolism. Next.
So I'm just going to touch briefly on managing tension pneumothorax, which is always sort of like a very dramatic and very high yield procedure if you have the right diagnosis. So it involves taking a needle in and basically popping the pleural space such that it can decompress and that the lung that's inside the pleural space can re-expand. The two places that I like to put my needle is you can see in the image on the right, there is a second intercostal space. It's above the third rib, which keep in mind that the first rib is hidden under the clavicle. So when you're feeling on the surface of the body, it always feels a little bit lower than what you expect and anticipate that third intercostal space, second intercostal space to be located. Also, you can put the needle in laterally, so in the mid-axillary line above the sixth rib or so. But the truth is that the reason to choose these spots is because we want to avoid any great vessels that are in the mediastinum, and you always want to avoid any vessels that are running along the inferior aspect of the rib. So in any kind of lung and needle penetrating procedure, you always want to try to go just above the rib so you don't nick any of the vessels running inferiorly to the rib. In the interest of time, I'm just going to stop there. But I will say that since this is my last opportunity to address the group, this has been an amazing experience. I'm so blown away by the level of engagement and the brain power that is being displayed in our chat. And thank you so much, Dr. Crawford, for organizing all this, and Dr. Kaminsky for hosting. Oh my gosh, I took the wrong slide. Eunice, would you like to take this slide?
No, I think this is fine.
Okay.
Yeah, I was
So I should
was going to
I'm
manage,
so
but it's
sorry.
fine.
That is
No,
my
no, I
mistake.
think this was my slide. I think it's
Okay,
fine.
forgive me. Okay.
So we're just going to briefly, one of the things that we said that will causes of obstructive shock will be cardiac tamponade. And of note is that you can either have a slow accumulation or a very fast accumulation of the cardiac tamponade. Where you have an acute tamponade, that is an emergency. And in this case, this becomes a medical emergency and we have to evacuate the blood around the heart. So for us, when you want to do a cardiac pericardiocentesis, so the main thing is it will be wise for you to actually have it done. First diagnose, as we said, muffled heart sounds, hypotension, and the low electrical activities will be your guide for a cardiac tamponade. So the best thing, place an ultrasound with the most experienced hands. Place an ultrasound, you'll be able to see the fluid around the heart, and then you'll be able to do your pericardiocentesis, advance your needle, and you'll be able to withdraw the blood. Also, by this, you'll be able to tell if it is blood or it's a clot or it's even pus. But most of the time, if it is an acute accumulation, you might find it is mostly blood. So it is a take-home message, it is a cardiac emergency. And as you're doing this, remember you're having hypotension. For this patient, you're supposed to be ready. Have large bore cannulas, have your vasopressors nearby, preload your fluids also, and you can also raise the legs to actually increase venous return so that you can have a good preload in this patient so that you don't have an imminent collapse in the cardiovascular system as you're doing it. So ultrasound is key so that you can be able to avoid poking the heart and any great vessels. So that is my take home. Ultrasound, vasopressors, fluids, and raise your legs, lift the legs to increase
I
preload.
I would also add, because this is potentially related to an injury to the heart or great vessels, you should also be thinking about transferring the patient to a center that has cardiothoracic surgery if possible.
Definitely. Yeah.
Recognizing that that may not be possible for all patients.
Yes, definitely. Thank you.
Okay, thank you, everyone. So to finish up our discussion for today and to come back to our patient, Mrs. Diaz has a remarkable improvement in her status after excellent care that was provided by you all, her care team. And so if you see here, 3 hours later, she remains in the ICU for hemodynamic monitoring on low-dose vasopressors. Interventional radiology thankfully was able to perform catheter-directed thrombolysis with significant improvement in her hemodynamics, and her oxygen requirement continues to improve throughout her stay, and she now has a return to her baseline mental status, and her family is very appreciative of the care you've provided as well. So I'm going to take this time to say thank you, everyone who joined us today for the discussion. Thank you for all of our panelists who made time available in their schedules to help out with the discussion. And I know that we are tight on time. So Dr. Crawford, do you think we have time for a question or two, or should we reserve for later?
We have 3 minutes, so we have three Q&As. So I think one of the more relevant ones would be, what are the common contraindications of anticoagulants in pulmonary embolism? I did list some of these just now in the chat. So there are some absolute contraindications, and then there are some relative contraindications. So I will allow the panelists to discuss this, but just to start, discuss their experiences, but just to start, the absolute contraindications to giving thrombolysis would be a recent intracranial hemorrhage or cerebrovascular hemorrhage. Malignant or tumors in the brain can also be an absolute contraindication. Bleeding, active bleeding, such as like a trauma patient that has a vascular injury. Aortic dissection or uncontrolled bleeding in that can also be an absolute contraindication. Wondering if other panelists want to weigh in on contraindications to giving thrombolysis.
I do have one thing to say specifically for this patient, just because she did have a recent vaginal delivery. It is something to take into consideration, especially since she had bleeding postpartum. However, it's always worth thinking about the risk benefit in individual cases. And I think the panelists and hopefully most of you would agree that despite her having the recent vaginal delivery with bleeding as a complication afterwards, it has not been an ongoing problem for her. And right now, her medical emergency is the blood clot, is the clot that's causing hemodynamic instability. And so making sure that you weigh that risk benefit, but proceeding in the direction that's going to be life-saving for her right now, which would be addressing the clot with thrombolytics. This is also a good point to probably discuss with her OBGYN and the OBGYN care team to make them aware that this is what's ongoing and this is a potential risk, giving the thrombolytic so that way they can also keep an eye on bleeding. And you would be looking for any sort of adverse effects with bleeding, just regardless of the patient, and what their past medical history was, just to make sure that they don't have that complication giving thrombolytics.
Dr. Crawford, if you allow me, I shared
Uh-huh.
on the chat with everyone. MD Calc also has a, if you search TPA contraindications, it's specific for ischemic strokes, but it's good to keep in mind the different things that are listed there.
Yeah, I think Dr. Comiskey, your point is very well taken, and it's really, we have these lists that we try to follow, these contraindications, absolute or relative, but what really needs to prevail is what's going to save the patient. So sometimes you may have a relative risk, but the patient will die if you don't treat them, and so it's really what is more likely to kill the patient. Is it the clot and itself, or is it because they may bleed? So one case that I had personally that was a very, very difficult decision to make is I'm an anesthesiologist, and I actually pushed TPA during surgery. And that was a very, very difficult decision to make. But the patient was having surgery on their patella tendon. So the risk of bleeding to death from the tendon repair was much, much less than the hypoxemia and impending cardiovascular collapse. So I ended up luckily making the right decision, and the patient did very well. But that being in the middle of surgery and pushing TPA is not usually recommended. So I think Dr. Comiskey's point is incredibly valid. Although we have these lists of contraindications, we do need to do what's best for the patient in each individual situation. So I don't recommend giving TPA during surgery, but in that instance, it was appropriate. With that, I want to thank especially Dr. Comiskey and Dr. Pyland, who put this case discussion together. Thank you so much for all the hard work that you did to bring this together. I want to thank our other panelists who joined us. This is all voluntary. People are joining us from around the world. We're really grateful to all of you for sharing your expertise in patient care and helping us interpret some of this information and making good decisions on how to care for our patients. And I want to thank all of you for joining us. We really enjoyed doing this. We really love bringing you free education. Please scan this QR code if you want to access the slides and the notes, and also the point of care ultrasound bedside pocket guide. So feel free to do that now. A reminder that this session does have CME or CPD credits. However, you do need to fill out the evaluation. You will, if you registered, you will receive an email automatically. And so you should get a certificate of attendance. And if you fill out the evaluation, you will also get the CME credits as well. We look forward to seeing you next month. So we have a session every month through, I believe, October of this year. So hopefully you can join us again. And with that, I want to say thank you so much to everyone.
Thank you.
Thank you.
Thank you.
Can we go back to
Thank
the
you.
QR code?
Thank
Thank
you.
Thank you.
Thank you.
Thank
Thank you very
you.
much,
Thank
everyone.
you and
Thank
bye.
you.
Thank
Bye
you.
bye.
Thank
Thank
you.
you.
Thank
Thank
you.
you.
Thank you.
Thank you.
Thank you. God
Thank
bless
you.
you.
Thank you.
Thank
Thank
you.
you.
Thank
God bless you.
you.
Santi.
Thank you so much.
Thank you, everyone.
Thank you very much
Thank
for
you
your
for
presentation.
much.
This is
Thank
great.
you so much.
Thank you so much.
Thank you.
Thank you so much.
So much.
Thank you.
Thank you.
Very blessed. Thank
Thank
you.
you. Thank you.
Thank you.
Much appreciated.
Thank you.
Kazim Zuri.
Asante sana Anna.
Asante sana.
Don't let me sing.
Thank you so much.